Oh, yeah.
All right, guys, we'll go ahead and get rolling. This is a two-part series on the shoulder. When people residents come over to me, the shoulder seems to always be kind of the most intimidating joint to kind of tackle, examine, figure out what's going on. So try to break this down into two talks. So this probably won't take up the entire time, and we'll have a little time at the end if necessary. It's going to be a little more challenging from a standpoint of like demonstrating some physical exam stuff, but the slides hopefully will be enough. And certainly when you come around, I mean, you can honestly, like these days, Google shoulder exam and probably find everything demonstrated online if you have interest to pursue that. So we'll kind of cover the anatomy, go over the kind of biomechanics, physiology, mainly of like a throwing athlete, like what issues do they have and why, and then just go through some key things historically that you should be asking, and some things that an athlete or a patient might mention to you that would kind of tip you off as far as what might be going on. As you know, the mystery is always in the industry, right? Physical exam tends to just confirm what you're thinking might be going on. We'll go through some things in the differential diagnosis and then just kind of cover the physical exam. So from the anatomy standpoint, we'll start with the bones. So start at the base of things. When you're talking about the shoulder, basically you're concerned with the clavicle, the scapula, and the humerus. So the clavicle is really the only attachment of the shoulder to the axial skeleton, and that's at the sternoclavicular joint. Otherwise, it's just kind of, everything's kind of suspended there by muscles and fascia. Yeah, so the humerus is the ball and socket joint. Obviously, the AC joint or acromioclavicular joint is that junction between the clavicle and the acromion. And then the scapula is actually a point of muscle attachment for many muscles around it, but also your rotator cuff arises off the scapula, which we'll get to next. So the muscles of the shoulder, superficially, those are the ones you can see and feel most easily. Your pectoralis major and minor, which have an attachment on the humerus, kind of proximal medial. You can actually see this with ultrasound evaluation when you, in short axis, if you're evaluating the shoulder with ultrasound. You have your biceps, which has two attachments, one on the coracoid process, the other one is a long head that attaches up on the super aspect of the glenoid. Your trapezius is broad muscle that also goes all the way up to your to the base of your neck and skull. And then your latissimus and serratus have attachments more posteriorly on the shoulder and serve to kind of adduct and extend. Of course, I mean, most of the time there's not a lot of anything significant as far as surgical issues with those larger muscles around the shoulder. You know, the things that break down more often and become problematic with pathology are the deeper muscles of the shoulder, specifically the rotator cuff, especially when you're talking about the general community that you're dealing with, in addition to athletes. So the four muscles of the rotator cuff, supraspinatus, infraspinatus, subscapularis, and teres minor. The subscap, as you can see, kind of rises off the anterior aspect of the scapula and has an attachment on the lesser tuberosity. The supraspinatus, which is the most common tendon to have pathology in it, rises above the spine of the scapula and it's attachment on the greater tuberosity, along with the infraspinatus and teres, which you can see there more below the spine of the scapula. Honestly, like teres minor hardly ever has any significant issue unless somebody has just a massive rotator cuff tear where they tear all four tendons, which is somewhat certainly rare in sports and kind of rare injury anyway. Infraspinatus, again, some pathology, but not quite as common as supraspinatus. And I probably see more subscap. That's probably second in my experience on the things you see. The rhomboids, levator scapulae, those are muscles that arise off the medial border of the scapula. You can see on the lower picture there. People can sometimes carry stress and other things and have this pain kind of right at the superior border of the scapula. And a lot of times people will have weakness of their rhomboids that will cause the scapula to kind of track abnormally, which can contribute to some of the pathology we would see in throwers. So some of those scapular stabilizer muscles are important, especially just kind of for treatment and building up in a thrower or an overhead athlete that's having issues. Going to more like connective tissue that's around there, going a little deeper. You have the bursa. You can see on this, it's a pretty thin structure sitting just above the rotator cuff tendons. This is a cross-sectional view looking kind of axially at things. So it's kind of between the spine of the scapula and the cuff itself. That's where we do a lot of our steroid injections and other things, is within the subdeltoid or subacromial bursa. And then deep to that, then you have this, then you basically have the rotator cuff tendons laying on top of the capsule itself. The capsule is divided into some ligaments that they name. The anterior, there's a superior glenohumeral ligament, there's the middle, and then there's the inferior. Those are on the anterior side of the shoulder. And then you can also see that where the long head of the biceps is kind of cut on this picture and comes in and attaches on the superior aspect of the glenoid, and it actually has it kind of melds in or kind of phases into the superior labrum. And so that's an anchor that kind of stabilizes the shoulder that you'll oftentimes see in an overhead throwing athlete that will start to have some issues. You guys probably heard of a SLAP tear if you follow athletics, which just stands for superior labrum anterior to posterior. And it's that tugging of the biceps in that throwing motion that can cause that injury. Going a little further, nerves. I'm not going to go through necessarily specific nerves that pass through the shoulder, but basically any nerve that goes through the upper extremity has to pass through the shoulder area down into the arm. So there are nerve entrapment syndromes and other things that can cause pain in the shoulder area that can occur, from the brachial plexus. Thoracic outlet syndrome is not an uncommon, symptom that people might have. Obviously, these things arise from the neck, and so that's other things you need to be kind of aware of, and always remember when somebody comes in with a shoulder complaint, it may not truly be their shoulder. It could be referred pain from the neck, and so you just need to ask good historical questions to try and sort that out and see kind of what things aggravate it and don't to hopefully narrow down, is it shoulder or is this neck. Sometimes I have patients you can't quite tell; they just hurt everywhere, and those get a little more difficult. The vessels, subclavian, divide into brachial and then on distally. Again, rare to have anything in sports that kind of causes injury there, but again, with thoracic outlet syndrome, sometimes the circulation can be affected in some way. Upper extremity exertional DVTs do happen in athletes, rare thing to occur, but you can see people showing with this kind of acute venous congestion and pain in their arm that can happen from, a DVT that'll happen in the upper extremity. So any questions on the anatomy, at least kind of quick overview of those things. So with the shoulder, the thing that makes it great is it got such a wide range of motion. So we can reach lots of things. You can generate a lot of force for throwing, swinging a racket. But because of that increased mobility, then you have you sacrifice stability. And so it's a commonly dislocated joint. It's a common joint that has just instability and injury from the repetitive use of it. And so you just have to kind of be aware of what things are stabilizing the shoulder and how. And there are both kind of dynamic and static stabilizers that come into play and are stressed quite a bit when you think about a throwing or overhead athlete. So the static stabilizers basically are that the joint itself has some negative intra-articular pressure, so that helps to keep the ball and socket joint in place. Then you have the capsule, which wraps around there, has some name thickened areas like we talked about ligaments, but I just kind of generically call it the shoulder capsule. And then you have the labrum. The labrum is just this rim of cartilage around the outside of the shoulder. It functions to make that socket just slightly deeper, but it's nothing like when you think about the acetabulum in the hip. Hip joint dislocations are pretty rare athletic injury, certainly rare injury even in general compared to shoulder dislocations. And some of that is because that socket is not very deep, right? But think about how much motion your shoulder has compared to your hip. And so again, the function of it kind of determines that you have a less kind of deep joint in order for the shoulder to move. The ligament that kind of gets most injured is the inferior glenohumeral ligament, which is kind of stressed at the 90-degree kind of abducted, externally rotated position that the shoulder gets into. So then you get the dynamic stabilizers, and these are the rotator cuff muscles. It's most important in kind of mid-range of motion as you're kind of powering forward and accelerating in the throwing motion, and it serves to compress and depress the humeral head. And really that's what it does in all daily activities. So you think about people when they come in, they complain their shoulder hurts. A lot of times they can raise their arm to shoulder level, and that's not too bad, but it's when they start to get to that shoulder level and above that they have problems. That's because if their cuff is not functioning properly to kind of depress the humeral head so it can clear underneath the acromion, then you start to get impingement, pain, things are hurting. So that cuff dysfunction, you don't get that depression and compression of the humeral head. So when you think about injuries to the shoulder, most of the time it's a breakdown in the stabilizers in some way. That can be traumatic from a dislocation, it can be atraumatic from repetitive, kind of chronic overuse, or somebody that just has a loose capsule in general. So there are people that have, mixed connective tissue disorders, or, some of the, I'm blanking on them right now, but, where their connective tissue is very loose and then their shoulder just, slip out quite easily. And those are genetic issues. So when they have that, then your rotator cuff and muscles have to compensate for that. And that's where things can be a problem. Acutely, like obviously you can have dislocation, strain, and tears. So I think this is a good picture, kind of diagram to kind of explain kind of how these things interplay, and that instability leads to cuff pathology and vice versa. So if you think somebody has an acute, say, shoulder dislocation, well, now they have an unstable shoulder, and yes, things scar back down in, but now the cuff has to compensate for that loose capsule, which can cause, issues with like rotator cuff tendonitis and other things. Think of the other scenario, say with somebody just does throwing, keeps using their arm over and over again for swinging a racket overhead, or hitting a volleyball, or throwing a ball. Now their cuff's fatigued, just doesn't do its job as well. And so now, because this cuff isn't stabilizing the shoulder, the capsule itself and the labrum start to take more stress, and then those things start to break down. So, when you think of impingement, kind of similar issue as the shoulder's impinging on the acromion. Sometimes that's because of a bone spur that's developed, or because of the anatomy of the acromion. Now the cuff's not happy, cuff's not working right, and you get the same thing. So both those things kind of play off each other. And sometimes you have to somehow figure out what's the chicken, what's the egg, what's the main underlying issue that, got this athlete in front of you, or this patient in front of you. So when you're talking about history, when somebody comes in with shoulder pathology, especially if there's been some kind of injury, get a mechanism. Rotator cuff tears can happen in an athletic population, although you're talking about people that are young and don't tend to have rotator cuff tears in general unless it's related to trauma. But I've seen him like an outfielder diving for a ball and kind of falling onto an internally rotated and adducted shoulder, forces the humeral head down, and that cuff would tear off the top of the greater tuberosity. People in the general community, which tends to be people 40 and older that have cuff tears, will oftentimes be lifting something, carrying something, reaching out and lifting something. They'll feel like something tear or rip, or feel like this hot water sensation or a hot poker jamming in their shoulder. Those are things that patients have kind of told me along the years, as far as to kind of tip you off that maybe there's a significant injury to the shoulder here. Ask them what makes it worse. So again, that's a really important question when you're trying to figure out, is this neck or shoulder? If it's like my shoulder hurts, but I can move it around and it doesn't make it, makes no difference whatsoever. That to me starts to make me think, well, maybe this isn't truly the shoulder at all. This is really coming from the neck. But most people with shoulder problems, above shoulder level hurts, reaching behind their back hurts. If they have an AC joint issue, it's reaching, tends to be kind of across the body. That's more painful than out away from the body. So those kind of things can kind of tip you off as well. Nighttime pain is not an uncommon complaint with people that have rotator cuff tendinopathy or bursitis. They lay on the shoulder, or at nighttime when they try to relax, it just kind of aches or hurts them more. So it doesn't always make me go to malignancy or something bad. But I mean, as nighttime pain in general, especially pain that's waking people from sleep, is never a great thing, and always makes me a little bit worried about something more serious, such as a malignancy or tumor. But also a very common complaint with bursitis and tendinopathy. Referred pain. So oftentimes people come in and they say my shoulder hurts. They say, well, where does it hurt? And they just point to like it hurts right here, which doesn't seem like shoulder. Or they wrap their hand around their upper arm and say this is where it hurts. So it doesn't really seem like it's their shoulder. But oftentimes cuff pathology refers pain to kind of that area of the arm, sometimes even all the way down to the elbow. But if it's going beyond the elbow, makes you start to think at least about more of a cervical radiculopathy or something with the brachial plexus. And obviously cervical problems can radiate all the way down to the fingers, numbness, tingling. Sometimes it's just pain as far as distribution. People will oftentimes complain of some type of mechanical symptom, of noise, crepitance. Sometimes that is completely benign, especially if somebody's had previous injury or been a weightlifter or other things. Popping in the shoulder, if anybody here lifted weights or had some kind of injury to the shoulder, and I can roll my shoulder around and make it pop just about any time. Doesn't hurt. So crepitance isn't always ominous or something bad, but if they have reproducible painful noises, that's, that's more concerning, and it can go along with labral pathology, AC joint arthritis, or AC injury. Just, inflammation of the tendons can oftentimes make the movement of the shoulder start to be noisy where before it wasn't. And then instability, sometimes an athlete might complain of. They won't really tell you their shoulder's slipping out, they just feel like their arm's going dead. Like, it's just like, I got no power, it just won't, I can't accelerate my arm to throw a ball very hard. Sometimes they'll feel like something shifts or moves, and oftentimes they don't like to reach behind them. Kind of this abducted, externally rotated position is not a fun position for people to be in that have either dislocated their shoulder or have some anterior instability at least. So all good kind of things to kind of keep your ear out for as you're getting history. Any questions on that, or anybody else have any other thoughts? Okay. So things in your differential diagnosis of shoulder pain. Obviously, I work in orthopedic clinics, and musculoskeletal stuff is, the things we see the most often. Fracture, arthritis, tendonitis, bursitis, instability. People can get AVN of the humeral head, and those things can happen. Sprains, strains, all those things are quite common. These other things on the list are kind of things that at least keep in the back of your mind, especially in cases that just don't seem to be going like you think they should be going. Think about, is this a neurologic issue? Seen probably a handful of cases of brachial neuritis, which the name for that is Parsonage-Turner syndrome. You can oftentimes pick this up on an MRI. You see kind of this inflammatory pattern in the muscle distribution of some of the brachial plexus that a radiologist will call that. And a lot of times you'll see muscle atrophy of the shoulder girdle that'll come along with that. And sometimes they just come in and they didn't do anything. It's usually an older person that commonly have tendinopathy, but then you get not getting better, and then you get this inflammation. Unfortunately, like a lot of neurologic problems, it's tough to treat. You can send them to a neurologist, but difficult to reverse the effects sometimes. Cervical radiculopathy is super common. Thoracic outlet syndrome, like I mentioned, is another issue that can cause shoulder discomfort. These people with shingles, come in with just a shingles outbreak, and they say their shoulder hurts, and sometimes the pain comes on before the rash shows up. Time ends up revealing itself of what's going on there, but that's also something to keep in mind. Thoracic issues, obviously, especially with the patients you guys see, cardiac disease can cause shoulder pain. So people have peripheral angina, they might have, left shoulder discomfort. Lung carcinoma can present with shoulder discomfort, and then PE, and then you can move your way down into some of the abdominal diseases like peptic ulcer disease, cholecystitis, liver abscesses would cause more things on the right side, and then ruptured spleen would be, left-sided shoulder pain. Malignancy is kind of always on your list. Infections kind of always on your possible things in the differential. So, any questions? So things I go with physical exam, I tend to be pretty systematic about it. Take a look at the patient, see how they're sitting there. Go through the range of motion, strength test, and then special test. Again, always kind of keeping in mind, cervical and thoracic and other things as far as in your differential diagnosis on potential pathology. So range of motion, I check. I a lot of times the first thing I'll do is just have the patient move their arm as far as they can go. So you have them flex as far as they can forward. Moving their arm backward. You can always partially see me here. Abduction, raising it up to the side. And then a lot of times I'll just have them do horizontal abduction, just check all those motions. Then I'll do internal rotation by having them reach around their back this way. In a thrower, you might do kind of both active and passive internal rotation up in the 90-degree position. So, with that throwing position, and kind of see what the range of motion is and compare it to the other side. In a thrower, the throwing side should have kind of a movement of their arc more posteriorly where they're going to externally rotate, but the arc of motion should be the same. So, I'm about 180 degrees from here to here. And in a throwing shoulder, that might be reversed back a little further, and they might not be able to internal rotate as far, but the total degree amount should be the same. There are people with the throwing shoulder that get a tight posterior capsule, and their internal rotation starts to get limited. The other thing you want to pay attention to is look at their scapula as they're doing some of these motions. People can get what's called a sick scapular, have scapular dyskinesis. I have a picture of that on the next slide. And so if they have a shirt on, it's going to be hard to see. So get them into a gown, or or if the girls in a sports bra is comfortable, you just have them face the wall and look at their shoulder from the back and watch how the scapula moves as they abduct and forward flex. And this is very common in a thrower to see, or an overhead athlete that's swinging their arm regularly. And it's really related to some tightness of the anterior musculature you think about, all the things we're doing to accelerate our arm is a lot of the pull of these things in the front. And what it ends up doing is kind of tilting the scapula in the anterior direction. But when that happens, because, tight biceps and pec, that narrows the subacromial space, and then the rotator cuff starts to get impinged or get pinched up underneath the acromion in that position. So you can see on a couple of these pictures how the scapula is kind of winging out a little bit on the involved side. One thing you can have somebody do is like do a push-up on the wall, and you can sometimes pick that up as well. Long thoracic nerve injury can cause that type of thing too, where it causes winging of the scapula. But more often than not, it's not really a problem with that nerve; it's a problem with the scapular stabilizers. Does that make sense? Okay. So and then after you've checked motion, I just go to testing their strength in the same planes that you just did. Check them in forward flexion, abduction. I usually check their horizontal adduction strength, and then I kind of move on to empty can testing. You guys familiar with grading of muscle strength? So 5 out of 5 is obviously full, 4 out of 5 is a little weak. 3 is they can lift it against gravity, but they can't really give it much resistance. And then down below that, you have to eliminate gravity, or they can barely palpate the muscles moving. So again, same motions. The one kind of special test you do is the empty can test or Job's test, which is purported to isolate the supraspinatus. I think it's a pretty good test for that muscle, but the position for that is about 30 degrees of horizontal adduction. So not straight to the side, but bring it forward a little bit, and then turn their thumbs down like they're emptying a can, and then have them resist pushing up. And you can check both at the same time and pick up any weakness that they might have, or sometimes it's just as painful and their strength's pretty good. The other special test kind of strength-wise is called the lift-off test or Gerber's test, and that is for subscapularis injury or subscapularis weakness. Have somebody internal rotate their shoulder like pictured here, and then try to lift their arm off their back and press into your hand. You can check that from side to side for weakness there as well. The other thing that kind of reduces pain is called the belly press test, or just the opposite, kind of having somebody push into their belly and see if that, in more of an internal rotated position, and see if that reproduces pain. So we'll go through some of these special tests, and these are always the ones, there's names attached to all these things, and sometimes that's really overwhelming. You start to how am I going to remember all these names? I think more importantly is remembering one, to do the test, and 2, what are you testing? So if you don't remember the name to it, that's okay, but know that, well, that Job's test, I think, was this empty can thing. I think it tests the supraspinatus. So that way you can kind of figure out where your pathology is and what you're looking for. So the drop arm test is described here, but basically you abduct the arm 90 degrees or above, and usually I oftentimes do it passively. Sometimes the patient can't do it at all. So I'll be raising the arm up here like this, and a lot of times, that's farther than they can do on their own. And I'll kind of say, can you hold it there or let go? And a lot of times they can get there, and as they start to lower it, usually they get about right here, maybe just above shoulder level, and it's just like, they just can't hold it anymore. It just drops to their side, and it's like, I can't do it. Usually it's really painful for the patient. And so that makes it very suspicious that they might have a cuff tear. I've seen people with an acute injury within a couple of days that have that, and 2 weeks later they come back and they're great. So it's not 100%, but it certainly makes, kind of raises your suspicion that there's truly more than just a strain of things when they can't control that. So does that make sense? That's a really good, when you see that, be highly suspicious of least of cuff tear. AC compression test is like it shows here. Basically you're compressing, kind of stressing that AC joint by having somebody reach to their opposite shoulder. You can do it passively and kind of grab the elbow and press across like that. But the positive test is not going to reproduce just kind of general pain in the shoulder. You're going to be pain pretty much right here, right on top at the AC joint. So always ask them where it hurts when they say, if they do this test, they say, well, it hurts down here. That's not really a positive AC compression test. The impingement test, there may be more than this. These are the 2 that I tend to do, are the Kennedy-Hawkins test, which is, again, passive motion of the shoulder. You're basically holding onto somebody's arm, bringing it across here, almost like an AC compression test, and then you're going to slowly internally rotate like this, and that should reproduce their pain. Patient's not doing anything. This is all passive. And then Neer's test is also with internal rotation, which they don't really show here in the picture very well, but it's internal rotation of the shoulder, kind of adducted just slightly and passively raising it up overhead like this. and that should also reduce pain. Usually around shoulder level is when it starts, or maybe just below to about maybe 130 degrees, even in that plane of motion is when it causes discomfort.
I have a question.
Yeah.
So for Hawkins, like you're going into internal rotation.
Yeah.
Is that testing more the subscapularis, like versus if you took it, if you did the same thing but took it into external rotation, it's a new line instead of like the pterygonometer or infraspinatus, like the opposite way? Like does it work like that?
So yeah, no, I understand your question. So the question was with Hawkins test, is intra-rotation just testing the supraspinatus, and if you do more reverse it like extra rotation, can you impinge the infraspinatus or teres? Really, there's I don't know that you're necessarily impinging one specific cuff tendon when you're doing that test. It doesn't differentiate in any way. It's not going to really stress your subscap. I would say if you're doing more extra rotation, if anything, you're stressing the subscap tendon because it's more anterior. But there's really no like specific impingement test for a specific rotator cuff. Does that answer your question? Any other questions people have at this point? Okay. So biceps tendinopathy, oftentimes really typically more anterior shoulder plane. Long head of the biceps comes here. Short head attaches on the coracoid process. And there are two tests shown here for biceps and pathology. One is the speeds test. Basically, you're having somebody resist forward flexion with their palm up. Should cause pain, again, kind of anterior shoulder if it's truly just biceps pathology. And then Jurgensen's test is a combination of flexion of the elbow and supination at the same time. So I a lot of times just shake somebody's hand, in this position, then have them try and turn their palm up and flex their elbow as I resist it. And again, should cause pain kind of anterior shoulder, not elsewhere to be a positive test. So speeds and Jurgensen's are two biceps tendinopathy tests. You're looking at instability of the shoulder. Again, I don't do these routinely on people. If somebody didn't have trauma, if maybe I'll do it in a overhead athlete that's having some issues because maybe they have some baseline capsular laxity or something. But in general, they're 50-year-old guy like me coming in with some shoulder discomfort. I'm not going to literally lay them down and do some of these apprehension testing. But most instability of the shoulder happens with it anteriorly if there's been trauma or other things. So you lay them on the table, have the scapula stabilized on the table and the humerus just off the edge of the table. You passively move them into abduction and external rotation. You can imagine me laying down. And as you do that, it should, if somebody's had true, instability like a subluxation or dislocation, maybe spontaneously reduced, that should cause pain and the kind of a fear that it's going to come out again. Sometimes it's just pain. One way you can kind of confirm this is once you get into this position like that's painful, then you, as shown in the picture on the right, you apply some pressure on the humerus to translate it more posteriorly, kind of take that stress off the anterior capsule, and that should make it feel better. Then you start to release again, they're like, ooh, don't like that. So that kind of shows that there's maybe some anterior translation of the humeral head when they get up in that position. Other thing you do is just kind of more passive tests of the stability of the humeral head. You kind of pull down on the elbow, and you'll see a little sulcus show up off the edge of the acromion. So this little divot will appear. That somebody has inferior capsular laxity. And then the other thing you do is a load and shift test. So just like shown here, somebody's just sitting on the exam table or in a chair. You kind of grasp the humeral head in between your fingers, thumb and fingers, and try and glide the humeral head anteriorly, glide it posteriorly, and see how much movement you have, and you check the other side. Because some people have some kind of capsular movement anyway. And you can feel it, people that have some looseness, you'll feel it almost get to the kind of the edge of the socket. You're like, ooh, that kind of moves quite a bit. This is harder to do on muscular people, because they have big deltoids and it's hard to grab and shift things. But a really good test, and you'll pick up on some things, instability-wise, that you may not pick up otherwise if you didn't do it. So labral tests. Labrum is a common thing we see in growers as far as having pathology because of that biceps attachment on the superior labrum. There's O'Brien's test and crank test. O'Brien's test is almost like an empty can test, but you're bringing instead of having your arm out here at about 30 degrees of horizontal flexion, you're about 10 degrees, almost 10 to 30 degrees of adduction across your body, and you have patient resist pushing up here. That should cause pain. And then when you turn the thumb up and do the same thing, it should be less painful, or you can do it with the palm up. It should be less painful. So that's a positive O'Brien's test. Crank test is similar to like meniscal testing in the knee. So you're trying to compress the humeral head into the socket and then just kind of jimmy it around to see if you can catch that torn piece of cartilage around the edge and either cause some painful popping, sometimes just being as you kind of internally and externally rotate the shoulder or kind of circumduct it to try and catch that labral tear. So one caveat about labral testing, not very sensitive or specific. So even if it's negative, it's probably 50-50 chance that they still have it, you know, based on your testing. So positive test, same deal. Is, I mean, literally sensitivity and specificity is not better 50% on any label test. So go with your clinical suspicion, and if you think you may have it, you got regular imaging. Sperling's maneuver, good picture of doing that here. And in this case, they're doing it passively. So you're passively moving the neck into extension and rotation towards the ipsilateral side. If that reproduces their shoulder pain or reproduces radicular symptoms down the, radicular symptoms down the arm, is what I would call a positive test. Similar to, in my note, most of the time when I at least describe a positive, I don't say positive Sperling's. I just say Sperling's would cause pain in the shoulder and numbness and tingling in the thumb and index finger, or numbness and tingling that went down to the mid forearm and stopped. So that way it's more descriptive. If you have an idea of your dermatomes, myotomes, you can kind of hone down on what nerve you think might be involved if you start to further evaluate their cervical spine. You don't have to do this passively. You can have the patient actively do it. So let's just say extend and look up and then rotate, to the side that they're complaining and see if that reproduces really well. So like I said, this one doesn't take up the whole time, but we'll get more into kind of pathology if they, looking at specific cases and kind of management of some of the shoulder things that are going to come across in your practice. So, biggest thing, know your surface anatomy. Like anything in MSK medicine, you got to know your anatomy. What structures are there? What do they do? What's their function? And it just gets so much easier once you have a pretty good grasp of that. Understand the roles of dynamic and static stabilizers in shoulder pathology. Make sure you get a good history, figure out what makes it worse, what makes it better, how did it start in the first place. And then just be systematic with your exam. Don't get overwhelmed. Start with motion, then check your strength test in the same motions, and then move on to your special tests after that. Check for instability, when you need to. And then also just, keep in mind your broader differential diagnosis. So again, I'll have more next week as we go into some pathology stuff. So any questions I can answer?
I'm pretty sure that's because of those should be overweight that people commonly do.
I don't know that I would avoid any. I just use them. I guess just like any test, understand the limitations of the information that you're getting based on the test. So yeah, I don't know that I avoid any. I definitely just hone, and this comes as you get more experience. You're not going to do every test on every patient. You already, based on the history, probably have some idea of some of the things that might be going on. That's a little bit of a trap because sometimes you might miss something because you think you got it figured out before you examine the patient. But I don't know if there's anything necessarily to avoid. And sorry, I didn't repeat the question. So the question was, because of the poor sensitivity and specificity of some tests in the shoulder, is there anything that you would avoid? So. So, yeah, question was, do I use a lot of ultrasound in my clinic? I do some diagnostic ultrasound in the shoulder. The one thing I've been told two different things, and I think you can, from a billing standpoint with the shoulder, most of the time they expect you to do a complete shoulder exam, which is identifying, I think, 8 different structures you have to document by picture and with a report. So with the busyness and kind of walking clinic nature of my practice a lot, I don't have time. I don't have a tech that can do it. You can bill for limited diagnostic ultrasound of the shoulder. I originally was told you couldn't, but I'm pretty sure you can, because I'm pretty sure I've gotten paid for it. So yes, I think that is a nice tool to have. Certainly is a pretty good learning curve in that, but it's something you can master for sure. I mean, most sports medicine fellows, or people that go to sports medicine fellowship, are taught musculoskeletal ultrasound pretty extensively, and you come out with competence both diagnostically as well as for injections. So it's a nice thing to be able to do. You know, the tough thing, the harder patients to do are the ones that are obese. You know, when you have a lot of adipose tissue, it just limits your exam and it makes it difficult. So, and sometimes, unfortunately, sometimes those are the people that also have a difficult time getting inside of an MRI unit, so they're asking you to do an ultrasound instead. And so it's like, well, still going to be limited on what you do. So, any questions? Any other questions at all? All right, guys. Hope that's helpful. See you in a couple weeks.